Good afternoon, jury, colleagues, and committee that already set up this conference. Here I am, Lathifah Dzakiyyah Zulfa from Faculty of Medicine, Kristen University of Indonesia, presenting my theme systematic review and meta-analysis about prevalence of intracranial hemorrhage after recombinant tissue plasminogen activator treatment for acute myocardial infarction. So cardiovascular event itself often leading to death, while the most severe deaths were due to ischemic heart disease, around 47% in the world. By 2050, it predicted that CVD burden in Indonesia will be 109% increase. The management goal of acute myocardial infarction is early restoration using thrombolysis strategy, especially in developing countries. Thrombolysis strategy, as European Society of Cardiology proposed for late treatment that often happen in developing countries, could use plasminogen activator, whether it is fibrin-specific or non-fibrin-specific. The recombinant plasminogen activator, namely alteplase and tenecteplase, works systematic way, causing the double-edged sword phenomenon, which means it could also make bleeding elsewhere, one of which is intracranial hemorrhage. The objective of this study identifies the rate of intracranial hemorrhage in RTPA-treated myocardial infarction patients and also compare the intracranial hemorrhage risk from different types of RTPA, the alteplase and the tenecteplase. The study protocol already reviewed on Prospero and approved for publication in the register. Our literature searching has been done in some databases and register like PubMed, Google Scholar, and Cochrane Register with research terms intracranial hemorrhage, RTPA, recombinant plasminogen activator, and myocardial infarction. And here is our small flow with 4 studies included, with eligibility criteria such as prospective cohort, randomized control trial, or case series that reporting the prevalence of intracranial hemorrhage after using RTPA for treating the myocardial infarction in that patients. The risk of bias and quality assessment are done using 2017 American Academy of Neurology guideline as this study using for intracranial hemorrhage in neurology department, while the publication bias are using rank correlation test Kendall-Tau. For statistical analysis, we use 2 different software, the full prevalence using comprehensive meta-analysis and the subgroup analysis. We are using SPSS for the odds ratio and random effect of meta-analysis. And here is the result. For publication comprising 21,019 participants, there is no significant baseline difference from the subject included from these 4 studies. And the risk of bias of the study for the studies included are low, while 1 publication classified as moderate. From our meta-analysis, the pool prevalence of intracranial hemorrhage in RTPA-treated myocardial infarction patients are just 3% from 21,019 participants. The tau square score are more than 0.005, which means are not significant, indicate there is no publication bias for this meta-analysis. The next analysis result is no significant difference on intracranial hemorrhage after get treated with tenecteplase versus the one that get treated alteplase. But the publication bias remain high, which could due to the lack of literature that could be included, just 4 of it. So, after systematically reviewed the RTPA-induced intracranial hemorrhage from some literature, the prevalence are affected by individual risk factor, medication error, and also dosing and time to treatment, which is ranging from new onset to 4.5 hour. In the study, where the standard dose used, the pool prevalence of intracranial hemorrhage after RTPA treatment remains low, which is just 2%. So we can conclude the thrombolysis using RTPA considerably safe in the brain hemorrhage risk. The different types of RTPA drugs, alteplase and tenecteplase, also didn't alter the prevalence of intracranial hemorrhage. The limitation of our study is the number of the study included that is so little, just 4 study. So more study needed to be included by extending the publication time range to lower the publication bias on the subgroup analysis. And here is the reference that we took for our study. Thank you for your attention.
Such an interesting topic. Please give a round of applause. Do you have any comments or any questions?
Thank you for your presentations. I'm just curious about the included study. I saw the one that have the same authors, but different year for, 1999 and 2001. Are they the same study or same population? And the previous one is a preliminary, and the second one is the final paper. Could you?
Thank you for
yeah.
Thank you for the question. So the first 2 study is not the same study, and the first one that published in 1999 is not the primary one. It also took from different hospital, and the description of the study. The first one is just to report how much people get intracranial hemorrhage from getting the tenecteplase, while the second one, they use control the alteplase.
Okay, thank you.
Can I ask about the slide that you show, the difference between the types of RTPA? Was the study comparative at the study level, or are you combining it later and compare later? Can you explain us more here?
Thank you for the question. So they use the same method on their statistical analysis, and I use the odds ratio, not using their reporting on the prevalence. Then I combine to the forest plot. Then here's the random effect model that I get.
So this is odds ratio, right?
Yes.
And the odds ratio is equal to 0?
Yeah, the overall odds ratio is equal to 0. That's why I concluded as there's no difference, significant difference.
Which is very strange for a ratio of 0. Maybe I'm not sure whether it's possible for odds ratio to equal 0. Okay.
I also use some literature that it costs because the study group is just 2.
Okay. Thank you.
So much.
It might be to log odds, right, Ajahn? Maybe due to its being log odds, which is maybe odds ratio equal 1. Okay.
Thank you so much.
Thank you very much.